Let's start off by drawing a heart. We've got the right atrium and the left atrium. Remember in atrial fibrillation that the atria is fibrillating at a very high rate. These rates are anywhere between 220 to 300 beats per minute. Now the ECG will show a narrow complex QRS, which means that the QRS is less than 0.12 seconds. There will be an absence of P waves, and the rhythm is going to be irregular. In some of the leads, you will be able to see fibrillatory waves or fib waves. We'll see examples of these in the coming videos. So let's draw a heart again. We've got lead V1 over here and V2 over there. We can see that lead V1 is closest to the atria, and hence it is able to detect the fine oscillations or the fibrillation of the atria as well. And hence you see a chaotic baseline in lead V1, which shows us the fib waves. So when the rates of the atrial fibrillation are too high, there is a pseudo-regularization. The irregular RR interval is quite inappreciable. The classification of atrial fibrillation is based on the ventricular rate. So atrial fibrillation with a rapid ventricular response is any AF which has ventricular rates higher than 100 beats per minute. Atrial fibrillation with a controlled ventricular response is anything between 60 to 100 beats per minute. An atrial fibrillation with a slow ventricular response is when the ventricular response or the ventricular rate is less than 60 beats per minute. There are some conditions in which the ventricular rate regularizes. These are complete heart block, antiarrhythmic medications such as flecainide, and some cases of digoxin toxicity. You can differentiate atrial fibrillation from atrial flutter by using the calipers test. We will take a look at an ECG later so we can practice this. There's another thing we need to understand, which is cycle length. Current takes a set amount of time going from point A to point B because of the fixed velocity of it. Now in atrial flutter, it goes from point A to point B through the entire atria in a fixed pattern, in a fixed circle. So the cycle length is usually more than 180 milliseconds or more than 4 small boxes. As opposed to that, the current in atrial fibrillation is quite haphazard and it doesn't take a full turn around the entire atrium. So the cycle length can be less than 160 milliseconds. Remember that the cycle length is appreciated by measuring the distance between two consecutive flutter waves or fibrillatory waves. In some cases of coarse AFib, the cycle length can be more than 180 milliseconds. The clinical classification of atrial fibrillation is quite important as well. So paroxysmal atrial fibrillation is more than or equal to 2 episodes of AF, which resolve spontaneously. and this is within the last 7 days. Persistent atrial fibrillation is AF that lasts more than 7 days, or it usually lasts less than 7 days, but it needs cardioversion to be reverted back to sinus rhythm. Then we've got long-standing atrial fibrillation, which lasts for more than a year in duration. And then we've also got permanent atrial fibrillation, which lasts more than a year in duration, but there has been a clinical decision made to not revert it back to sinus rhythm. So let's do some practice ECGs. So you can appreciate a RR interval here, and then here again. You can appreciate that the RR interval is irregular. There is no P waves. And then you can see a chaotic baseline at V1. This is atrial fibrillation. And the ventricular rate is controlled. It's between 60 beats to 100 beats, so it's a controlled ventricular response. Again, you can appreciate irregular RR intervals. There are no P waves preceding the QRS complexes, and there is a chaotic baseline in V1. So that's a atrial fibrillation again. You can practice measuring the distance between two consecutive fib waves to see what the cycle length could be. Again, irregular RR intervals. Absence of P waves. Not much of a chaotic baseline in V1. Again, this is atrial fibrillation, and some parts of this strip would be a rapid ventricular response as well. So this is another irregular RR interval. Again, absence of P waves. This is atrial fibrillation again. One more thing we need to understand in this strip. So you've got the typical findings of atrial fibrillation again, but if you look at V1, you've got a long, short RR interval, which results in a Ashman beat, which comes from the atria. This is a benign phenomena that happens in atrial fibrillation.
Finally, let's do the calipers test. This test is to differentiate between atrial flutter and atrial fibrillation. If you try to map out the flutter waves on a flutter strip, you will see that they map out quite evenly and there is irregularity between them. This points towards organized atrial activity, which can happen in flutter. If you try to map out the fibrillatory waves on an atrial fibrillation ECG, you will see that they don't really map out evenly and there is irregularity between them. That points to the fact that this is atrial fibrillation.
That's all for today. Let me know in the comments section if this was helpful or not. Don't forget to like, share, and subscribe to the channel, and have a good day.